Hello all, this is Dr. Alsup, and we are going to finish off our discussion of the regional musculoskeletal anatomy of the head with the muscles. So we've talked bones, we've talked joints, and now let's talk about the muscles when they contract that will move those joints. And so we have quite a bit to go through, but I think you'll find that if you kind of group them together in terms of their major functions, it'll be a lot easier to kind of think about them in those ways. So we'll start with muscles of facial expression. Then we'll talk about the extraocular eye muscles, the ones that are going to move the eyeball. We will talk about the muscles of chewing, or muscles of mastication. Muscles of the soft palate. We talked a little bit about the hard palate already, so let's talk about those muscles that are going to be attached and create the soft palate. And then last but not least, we will finish our discussion with the muscles that make up the tongue. So, muscles of facial expression. These are relatively thin muscles that are pretty unique in the fact that their distal attachments are going to not be so much on bone, but instead they will have a connection to the subcutaneous tissue, which will be reinforced pretty tightly with some more dense connective tissue and some fascia. And so when the muscles contract, the muscles of facial expression contract, they will actually move the skin of the face to allow for facial expression. So that is something unique. Most of the muscles we're going to talk about have an attachment to bone, but when we're talking about muscles of facial expression, it is going to attach to those layers that allow for the skin to move. And as something very well named, the innervation of these muscles will be the facial nerve or cranial nerve 7, and it will be after the facial nerve has exited the skull. It will send off many of its motor branches to these small muscles all over this region. Now, if something happens, so the facial nerve will kind of come out right around this region here, and you can see it's sending branches all over the place. If the facial nerve is compromised, as in it is going to have some type of lesion or compression, it could affect the signal that allows for these muscles to contract and cause what is referred to as facial paralysis, or more commonly you hear it referred to as Bell or Bell's palsy. And what this is unilateral or same-side paralysis of the facial muscles. All right, so total ipsilateral facial muscle paralysis. And you can see that the individual have kind of a drooping corner of the mouth, unable to really keep that any of the fluids that are within the mouth in there. There'll also be a drooping eyelid and an inability to wrinkle the brow because you would need contraction of the frontalis muscle in order for that to occur. This facial paralysis can be differentiated from a stroke, usually because an individual with facial nerve paralysis will not be able to wrinkle their brow. All right. Whereas an individual suffering a cerebrovascular accident, or CVA, or stroke, as we more commonly hear that referred to as, they will often present with the inability to contract muscles of the lower face, but still maintain the ability to wrinkle their forehead. And this is due to the upper motor neurons for the cervicofacial division of the facial nerve being derived from the contralateral or opposite side of the cerebral cortex, so this would not be affected in that cerebrovascular accident. All right. So the key here for Bell's palsy is pretty much all the muscles of facial expression on one side will not be able to contract, and you will not have those typical movements. So there are a lot of muscles of facial expression, and we are only going to talk about a few of the larger ones, kind of the big picture money item ones, and be aware that there are numerous others if you ever go into some type of more directed head and neck anatomy course, you'll get into each one. And we're going to start with the orbicularis oculi. And this name kind of says it all. Orbicularis gives you an idea that we are talking about a sphincteric muscle who the muscle fibers are going to be circular. And so when these contract, it will cause for the muscle to close. Specifically, we are closing the eyelids. So you can see oculi right here, think eye. So we are closing the eyelids. And you'll have lots of sphincteric muscles. You'll have another one associated with the face, and then you'll have them throughout the body as well, and we'll talk about those as we make our way through the rest of the regional anatomy. The buccinator is going to be our cheek muscle. So it's the majority of the muscular portion of the cheek. And what is cool about the buccinator is that it is kind of on a deeper plane than the rest of the muscles of facial expression. So you can see these are all a bit more superficial, and then you have to look a little bit deeper in order to see the buccinator. But it's still a muscle of facial expression. It is still innervated by the cranial nerve 7. And what this muscle does is it's going to really press that cheek against the molar teeth, which will keep food out of the oral vestibule. And the oral vestibule is that part of the inside of your mouth where your teeth, that space in between your teeth and your cheek region. That is the oral vestibule, and you don't want food stuck in there. And so that buccinator will kind of press against that and send it back towards the oral cavity proper to allow for movement through the pharynx. The other sphincteric muscle associated with muscles of facial expression is the orbicularis oris. So think oral cavity. And so this is going to close the oral fissure, which is basically will close the mouth. It can also protrude the lips. So if you think about, your best kind of duck face for social media, kind of poking out the lips, that is also the orbicularis oris. All right. Moving on to muscles that will move the eyeball. These are sometimes referred to as extrinsic eye muscles, so they're not actually within the globe, even though they do have an attachment to it, but their proximal attachment's not going to be of the eye. Sometimes you hear them extrinsic eye muscles or extraocular eye muscles. You'll hear them both ways. But there are 6 of these, and these are all attached to the sclera. And the sclera, more colloquially, we refer to the sclera as the whites of the eye. So it is going to attach onto the globe, specifically the whites of the eye or the sclera. Now, most of these muscles, 4 out of the 6, will be innervated by the oculomotor nerve or cranial nerve 3. So oculo, right in its name, should give you an indication, okay, I think we're talking eye, and motor should tell you, okay, I think we're talking about efferent or motor innervation, allowing for contraction. So 4 out of the 6 are going to be oculomotor, and we have 2 exceptions. We have the lateral rectus, which is on the lateral side of the eye, as its name would suggest, is going to be innervated by the abducens nerve or cranial nerve 6. And the superior oblique, which is way up here, is going to be innervated by the trochlear nerve or cranial nerve 4, which that trochlear nerve is the smallest cranial nerve. And so the only thing that the abducens does is innervate lateral rectus. And the only thing that the trochlear nerve does is innervate superior oblique. So, if you have injury to, say, the oculomotor nerve, you know, okay, there's going to be quite a bit that's going on in terms of the inability of the eyeball to move in its typical manner. But say you have injury to or a lesion on one of these 2 nerves, you can kind of get down to what's going on based on trying to test for the actions that can occur with those muscles. And we're not going to get into the specific actions for each specific muscles, but overall, the 2 main sets of movements that can occur at the eyeball are elevation and depression. So the eye looking up for elevation, or the eye looking down, so you can see up and down here. Or abduction and adduction, so the eyeball moving medially or laterally for adduction. There is also another set of movements that are kind of clinically important, which are intorsion and extorsion, where that top part of the eye kind of rotates medially or laterally, whereas we're talking more the whole bulk for abduction and adduction. But don't worry so much about intorsion and extorsion. Just kind of get an idea of these basic movements of the eyeball. And you can kind of test yourself if you look in a mirror and kind of make your eye follow your finger. You can get an idea of these actions. All right, moving on to muscles of chewing or mastication. And these are specifically moving the mandible. So all of these muscles, all 4 of these muscles, so there's 4 sets of these, or 4 pairs, are all going to have a distal attachment on the mandible, or an inferior attachment. And all 4 of these are going to be innervated by the mandibular nerve, or that 3rd division of the trigeminal. So let's talk about each one of these, because these are big muscles. They're very dominant when you're talking about the head region, so we should talk about each one. The first is the temporalis. This is the one where I said if you put your hands kind of around your temples and you clench your jaw, you'll feel a muscle contracting there, and that will be your temporalis muscle. So you will have a superior attachment of the superior and inferior temporal lines, mainly these inferior temporal lines, all the way to the coronoid process of the mandible. So that's that anterior projection. The condylar process is back here, and the temporalis is going to attach on this coronoid. And this is a strong elevator of the mandible, or closer of the mouth, with a slight bit of retraction, or bringing back towards anatomical position, bringing that chin back from a jutted out position. The masseter muscle, sometimes you hear this muscle referred to as the masseter, is another very robust, very large muscle. So if you put your hands now more on your mandible region, so the lower portion of your face, and clench, you feel it, I think, almost a more robust muscle when you contract that. And this is the masseter. So you can easily kind of palpate your temporalis and your masseter, not so much the other 2 we're going to talk about. So this is going to be on the superficial side of the mandible. So you see, you can't see the mandible here because the masseter muscle is completely covering it. And this is another very powerful elevator of the mandible, a very powerful closer of the mouth. And you can see that you have 2 pretty dominant muscles that are going to play a role in terms of closing the mouth. So that's kind of that dominant movement we're talking about chewing. This is a very complex muscle, so you'll have fibers running in different directions. And dependent on which fibers are contracting, these can actually be antagonistic to one another. So you can have protraction of the mandible as well as retraction of the mandible, dependent on the specific masseter muscles, or muscle fibers that are contracting. Now on the opposite side of the mandible, you will have a muscle that mirrors the masseter muscle, and this is the medial pterygoid muscle. And so this is, like I said, on the deep side of the mandible. It's not quite as robust as the masseter muscle, but it does have similar actions to what the masseter muscle has. So elevation, and specifically, more specifically, protrusion. And lastly, we have the lateral pterygoid muscle. The lateral pterygoid muscle actually has 2 different heads. You'll have a superior head and an inferior head here. And this muscle plays a role just kind of in stabilization of the TMJ, so keeping it kind of locked when needed. But dependent on which head is contracting, it can play a role in terms of depression of the mandible, And I'm putting a little star next to this because this is the first time we've seen depression of the mandible or opening of the mouth. So it's really only this inferior head of the lateral pterygoid that can play a forceful contraction in terms of depression. Gravity can play a role in terms of depression as well, but when we're talking about conscious, forceful contractions, we're talking to the inferior head. The superior head will also play a role in terms of protraction of the mandible. So you can see that most of these muscles, all of these muscles in fact, will have some role in terms of that gliding action of the protraction and retraction, which isn't as easy to conceptualize, but very important in terms of the smooth movements that occur for mastication. Moving to the soft palate, and I want us to kind of get our bearings here. We're looking at a hemisected or a sagittally sectioned head. So we're looking at the medial portion of this. You can see the tongue is here. You see teeth here. This is the hard palate. So that's that bony palate. And then from here, you have the soft palate. And you have 5 muscles that are going to play some role in terms of the formation of the soft palate. And you don't need to know the names of these. There's a few of them right here. There's going to be some up in this region with the muscle bellies there. Their tendons will extend to the soft palate. But there are 5 muscles in all, and most of these are innervated by the vagus nerve or cranial nerve 10, except for one. It seems like almost everywhere you always have one exception, but don't worry so much about which one is which. I'd rather you just have the main idea that they're mostly innervated by the vagus. So what happens with the soft palate is that you can have elevation and depression depending on what's going on with swallowing or kind of closing off the nasopharynx region. Not too much of a forceful movement there, but that soft palate is going to be on this end, kind of hanging off the hard palate region. And last but not least, we have the muscles of the tongue. And the tongue is a mass of muscles. And when I say a mass of muscles, I mean a mass. It is a fairly large area. If you go back to this image, you can see quite how large we're talking in terms of the tongue. It's this whole area down into here, all the way up here. All right, so it's a bit more than what you usually see, say, when you stick out your tongue. And then obviously it's also going to be covered by mucosa. And you'll have 4 extrinsic muscles that will play a role. So they'll have an attachment on the tongue, but as well as something that's not of the tongue. So that's kind of what's making it extrinsic. These are important in terms of altering the position of the tongue. So those big gross movements, say of sticking out your tongue or kind of moving it to one side, those big movements. Whereas the intrinsic muscles of the tongue, of which there are 4 as well, are much smaller. I would have to pull up this mucosa right here, and then you'd be looking at a lot of those intrinsic muscles. But these play a role in terms of kind of altering the shape of the tongue. So is your tongue flat? Are you able to kind of curl it up some? And all of the attachments for the intrinsic muscles of the tongue are both attachments are within the tongue. So the origin and the insertion all within the tongue. Whereas the extrinsic, the origin is outside, and then the insertion is going to be of the tongue. And these are all innervated by the hypoglossal nerve or cranial nerve 12, except for one, which is actually has its other attachment on the palate. And so knowing what we know about the palate, what do you think that this exception may be innervated by? Well, it's the vagus nerve, all right? So this specific one, the palatoglossus, has an attachment both to the soft palate and to the tongue. And so you can see it right there in its name. So palate, soft palate, to the glossus or the tongue. And it is not innervated by 12, but instead innervated by 10, or vagus nerve. All right. So there are a lot of muscles associated with the head. So relatively small area, but quite a few. The most powerful are typically described as the muscles of mastication. However, there can be some powerful movements associated with the tongue. And in certain areas where I do not have the names on this side, it may be in the images, but if it's not on the text over on this side, don't worry about memorizing those names. I don't want you to memorize the muscles of the soft palate, but I do want you to know the basics regarding all those muscles. Same thing for the muscles of the tongue. But if I did have any details on this side or my text portion, do make sure that you are familiar with those. So let's go over a question together. And I love this type of question. This is certainly a type of question you may see on an assessment. So an individual has a damaged trochlear nerve or cranial nerve 4. Which muscle may be affected? So this is naming muscles, or these are extraocular eye muscles. So inferior oblique, lateral rectus, medial rectus, superior rectus, or superior oblique muscle. So recall that there are 4 out of 6 of the extraocular eye muscles are innervated by the oculomotor nerve. And there's 2 differences. There's one innervated by the trochlear, and that's what this question's asking for, and the other by abducens. So the abducens is cranial nerve 6. That will innervate the lateral rectus. All right? So this is not the right answer. No. And this is not this indicates wrong, not cranial nerve 10 here. So we are talking, the abducens is cranial nerve 6. And the trochlear nerve is that other exception, and it is going to innervate the superior oblique. So that is what this question is asking here. So if you have a damaged trochlear nerve, then the superior oblique may be affected. These other muscles, superior rectus, medial rectus, and inferior oblique, will be innervated by the oculomotor nerve or cranial nerve 3. All right. So that was a lot of fun. We are going to now move regionally. So we're going to continue our movement in the more inferior direction. So our next stop will be the regional musculoskeletal anatomy of the neck. As you review these topics, if you have any lingering questions or want to kind of clear up some concepts, please always feel free to reach out to me. And thank you for your time and attention. Have a great day.